Well, our guest today is Peter Castillo, a urogynecologist practicing in the Bay Area. He and I have worked together for a number of years, and we do things very similarly. And so it's great to have somebody on who's another vagina doctor. I feel better under those circumstances, but there's a little bit of support, so it seems. He speaks so eloquently of the problems that we face as providers and patients.
Yeah, I think of, Dr. Castillo and you and Red Alansad, who we had on just recently. Red referred to you guys as cowboys. Peter said the same thing. And I agree, you guys are cowboys. You're the type of cowboy that I am really drawn to.
Oh, that's good.
I'm happy about that.
But actually, the term that you used when we started this whole podcast idea was Maverick.
Yes, Mavericks in medicine.
Yeah.
And Peter Castillo is definitely this. So It's a great episode.
Yeah, I think so too. Very proud of it.
Enjoy.
But what do I know? I'm just a vagina doctor. Peter Castillo, MD, friend, colleague, and another vagina doctor. Welcome to the Vagina Doctor podcast.
Thank you, Duncan. This is a pleasure and an honor to be here. You and I go way back, and we've shared similar transitions in the way we practice medicine. And I love to see what you're doing, and I'm honored to be here.
Yeah, thank you. Likewise, I'm really happy you're here. We always have fun talking about things, and I learn something every time I talk to you. It's really great. I want to introduce Karen to the audience. Karen Spaulding is with us today. She's my right hand and so much more, but she will keep us on track. If we get a little too scientific, she'll correct us. And she's very capable of doing that, does it very well. Actually, you're a fellowship-trained urogynecologist, so you went beyond the OB/GYN residency, so it makes you a super vagina doctor as far as I can tell. Training in New York City, and then your Urogyn fellowship and a Cleveland Clinic in Florida. Then you were with Kaiser for a few years.
That's right.
And then what happened?
Well, in my pursuit for teaching and research and ability to sort of increase the awareness and knowledge of urogynecology in the community, my job was to find a place where I could do that. So at Kaiser, I did feel that I had not only the volume of patients, but access to residents, being part of the Stanford University as a assistant professor.
Yeah.
We were able to conduct research, investigator-initiated research at Kaiser with their large database. So there was a lot of great benefits to moving there, especially in the beginning, right out of fellowship. What I discovered over time, though, is I was in a simple way, I was becoming a fireman. What I mean by that, and this is, I think, the fate for many physicians as we train, we end up being the last person of resort for a problem. So we're a reactive medical society, right? We treat problems when they arise. We don't prevent, and we don't do any much more beyond that. So what we end up doing over time, especially as a specialist within a large system, is I put out fires. So I see a lot of patients that have problems that they've suffered with for many years, 5-10 years, only to be able to offer them a solution that can be handled within the 30-minute procedure or an hour-long procedure, or a therapy that would have put them on track way back when, but they didn't have that availability to them. So realizing that, I realized that I need to do more. Not just not that being a fireman is not a great job. It was a very fulfilling position because I could help a lot of women. Is that there's more. There's so much more to do, and there's so many areas of women's health that are being neglected or undertreated because of taboos and stigmas, and have pretty much everything we do as a urogynecologist are very common quality of life issues that are stigmatized: incontinence, prolapse, sexual health problems, menopause, and all the effects of aging falls into the bucket of what urogynecology is. So After 5 years at Kaiser, I realized that there's something missing in the community. So we decided to go out into the real world and start over. And we developed what we now call our Swan Medical Intimate Wellness. Intimate wellness is a broad term. It's not just about intimacy. It's all about intimate concerns that bother women that they don't talk about.
Yeah.
Right. So you can see how there's that in itself really opened doors for a lot of patients that realize that they can come and speak to us about whatever their problems are. And if we can find a solution for them, we will.
Yeah. I think that we would agree that Turner Medical Arts has been on a similar parallel program. It was really a matter of having more menopausal patients in my practice that I was running into these issues. And then some technology change. We had the lasers and radiofrequency treatments for vaginal treatment of genitourinary syndrome of menopause. That I mention this frequently about an example of the tragedy of women's healthcare has experienced of genitourinary syndrome of menopause didn't get a name until 2014. Well, did they suddenly have those symptoms then and hadn't had them for the last 200 years or whatever, if they live long enough? And that, as you know, and just basically for patients that are listening, people that are listening, that's a collection of symptoms associated with menopause, low estrogen, childbirth, and aging that can cause all sorts of vaginal issues and bladder issues. And that's right in your wheelhouse. But how did you start talking to patients about this? Because I know what I did, but it wasn't, as gynecologists, we were never taught to talk to people about sex.
Right.
And for two old bald guys, me being considerably older than you, talking to women about their orgasms was maybe a little difficult.
Yeah. And I want to just point out too, that you are two guys. So, right there, you're kind of a little bit at a disadvantage.
Yeah, it's true. It's true. I think something that we realize and maybe subconsciously realize as OBGYN based trained physicians, during training, you're literally thrown into the mix. And within the first week, you've seen more and done more than you ever imagined you could ever do. But that also means that you have to be very efficient at getting through to the point, getting to the patient, get them to understand that you're there to help them. So you have literally about 3 minutes to have them forget that you're the 6 foot tall, bald male guy talking to them about their gynecologic issues. And I don't think that was a conscious thing. It was a natural evolution of what happens when you get thrown into the mix. But that's one part. One is getting comfortable with the uncomfortable, getting comfortable with women and their concerns. And what happens is if you're comfortable, so is the patient. So it's a natural evolution. It's not an intentional one. It's not one that I thought about and I went home and meditated about. It's one that I better get to work tomorrow and I better do this right. So first, that was the first step, is realizing that I'm here to help women and I'm good at this and I can help them. And I don't need to worry about me. I just need to worry about them, take care of them, and they will be comfortable with that. And that's been how I've trained my staff members that are male that have never worked in a female environment and I realized that the first time I hired a male staff member, I had to go way back into time to realize how is it that I'm going to help this person transition into this role. To take that many years forward, I realized I was never really trained well in sexual health or menopausal medicine or the taboo conditions that we don't really talk about. The things that people talk about in private and silence or suffer in silence. And it was a funny transition. I remember probably maybe 6 years into practice, I wanted to spend some time with a colleague of mine in Colorado, Denver. Oscar Aguirre in Denver. He's a colleague of mine. He's been a mentor to me as well. And I spent a week with him because his practice is really revolves around sexual health and cosmetic gynecology and intimate wellness. which at the time we didn't have a title. But I spent a week with him to learn how he addresses and speaks to patients, because these were terms that we were never taught and we never learned. So first I spent some time with him just to learn and listen and observe, and I would talk to his patients as well. But then when I went back home, that's a whole other process. How do I implement this in my own practice? And here's the funny thing, is that when I started practice after leaving the big box and opening my own practice, I had to start from scratch. And I had a patient a day. So I had a lot of time to talk.
And just to clarify too, were you Peter Castillo urogynecology, or were you Peter Castillo intimate wellness? What was that first step?
Excellent. Our process was an evolution of realization of what we're missing, of what's missing in our skill set. So I started off as urogynecology, Women's Pelvic Health Institute. So it was specifically to help pelvic floor issues, and I had this vision of creating this large pelvic health center, and I would have other physicians and providers and physical therapists and sex therapists and minimally invasive surgeons to address all the needs in the community.
I think that's when I first met you.
Yeah.
Was then, and you guys did a case together.
We did several cases together.
Yeah.
And that's really what I envisioned. However, because I was building a practice slowly, I had a lot of time, and patients are very accustomed to being rushed out the door because there's always somebody waiting. And I remember patients actually asking me, "I know you have to go," and I would.
They're like, "No,
not really." I'd say, "Actually, no.
We've got all day.
I've got plenty of time for you." And here's the turning point in all this, is that what we know now is called the door handle question. You know, the problem that patients come in to see you for, but they're embarrassed or not sure how to ask, so they come in for a regular visit.
Right.
And then if they feel comfortable by the end of the visit, just as you grab the door handle to walk out the door, I say, "Doctor, can I ask you one more thing?" So that door handle question is one that we're often missed. We often miss it because we're rushing. We're running in and out of the room, and we don't give them a chance to catch their breath or even think about that question formally, and they just get through the visit. So what that time bought me was that moment to capture the door handle question in a way that I had time to answer it. So that became the most. I
love that. We should add that to our patient intake forms.
Well, that's actually exactly what we did.
Yeah.
I mean, to get women to talk about sex and bladder issues even, we had to alter our entry paperwork. Mm-hmm. So we, instead of the usual questions, or as well as the usual questions that we'd ask with a new patient coming in, we would ask them if they were having any pain with intercourse or urinary incontinence. And that, for me, them checking that box enabled me to talk to them about it. So I could actually, before I hit the door handle, I would.
You already knew.
I already knew.
That's exactly.
And so that worked out really well. But one of the things that happened then was, I didn't realize how many women had problems in this direction. I thought, okay, it's going to be menopause and hot flashes and night sweats, and then they'll be okay. Because that's what we were told in our residency. Right. Just, give the HRT, hormone replacement therapy, for a couple of years, lowest dose possible, just to get over the symptoms, and then they're fine. Right. Well, they're not fine. And the absolutely staggering histories that I saw from patients is they haven't been able to have intercourse for 10 years because it's been painful. And they have been sexually inactive for that time. And their marriages have suffered for it. So being able to bring that up and then have treatment for them, whereas it may just have been estrogen vaginally with, a huge safety profile on it that just wasn't an issue despite the Women's Health Initiative studies, which we can talk about in a minute, just amazed me. And I saw how many patients we would be talking about, we would be seeing and talking about this. The other thing was that when we realized people had all these problems, we wanted to open the doors and we wanted to talk to, let people know, let patients know. Well, here in Santa Barbara, we couldn't say vagina on the radio, okay? And talking about intercourse was taboo. And actually, at Facebook and other modalities, we weren't able to do that.
That's right.
And so that's how we got these words like intimate wellness now instead of sex.
Right.
So,
right.
Not that they're exactly the same, but
yeah, I think a little bit more encompassing.
Yeah.
As an intimate wellness, if you really want to think about the potential areas of concern for patients.
Right.
I think what we've stumbled upon is something that has been centuries old. That finally, the discrepancies in health for women, particularly with regard to sexual health, are starting to come to light, and the realization that they don't need to live in silence with these problems.
So I want to go back though, because when did you kind of transition from the Urogyn to intimate wellness? So how many years were you doing?
It was probably about
with one or two patients, and I have all the time in the world to wait a minute. This is real, the real deal. I gotta.
Yeah. Well, then it really began. Then the training started. I still had struggles with myself. I think what happens is not only helping patients as a realization that there's a need, it's also the identity crisis that one has to go through to realize the kind of practitioner you need to become to help these women. And I call it an identity crisis because you struggle. Because now we're venturing into the unknown, which means that also your mentors and those that preceded you, that led you to where you are in your career, you're leaving the tree. You're leaving the mother tree, and you're sort of outside of the you're off the reservation, if you will. So when you start practicing into areas that they don't understand, you're a cowboy, right?
Right.
And then offering treatments which didn't exist before now do exist. You're offering therapies that are off-label or experimental, or whatever terms they want to put to it. But the realization that there's so much data, and all therapies that we offer in medicine all started somewhere. Data then builds, and over time, clinical experience and data support its use. But that takes decades.
Yeah.
So I think we're on the frontier of a whole new wave of medicine that is driven by patient demand, patient concerns and demands, and realization that they don't need to live in silence is allowing these type of therapies to flourish and do well, and find solutions for these patients.
It's I agree with you 100%. This is we've been fighting that all along ever since we started doing this. For me, it was another chapter because I had the same issues with my colleagues over minimally invasive surgery. From starting doing that in the mid 80s, when we were still looking down a scope and we didn't have a video camera to use. And really feeling so strongly that this was so much better for women, or for humans generally, to have minimally invasive surgery, but couldn't get my colleagues to use it at all. And all that happened was I got criticized for it. And fortunately, my patients didn't listen to the competition. They listened to me most of the time, and we were able to slowly progress. Of course, everybody's doing it in the minimally invasive fashion now, but that was 30 years ago, 40 years ago. So it was just another frontier. But you and I are in that same position now. The American colleges of American College of OBGYN is still not supporting the idea of the non-invasive treatments with lasers and radio frequency.
Right.
I don't understand why.
Well, there's a process of acceptance in the medical world, particularly in the academic world. The process has to go through evidence-based practice, right? So demonstrating safety, efficacy, and superiority in order to adapt something new. So there's a lot. That's a big hurdle to handle, particularly with something that's new. Any kind of new practice, whether it's laparoscopic and minimally invasive surgery, to new frontier therapies like laser therapies, which are not new in medicine. They've been around, and dermatology.
The energy sources have been used forever. I mean, It's just for decades has been the case. Yeah, absolutely.
So the process is long, and so of course, they always like to hang the hat on the randomized controlled trials, double-blind randomized controlled trials, which means that that is your level 1 evidence for something. That's a very difficult study to do with conditions that are still understood, that are yet to be acknowledged. And the residents that are coming out of practice now aren't even trained in recognizing the conditions. So it's going to take a long, long time. That said, there is lots of data dating back to the early 90s or even late 80s, where laser therapy is used for vaginal care worldwide. But these are small cohort studies that over time build to a larger body of knowledge, which we're developing. I've been involved in research. We continue to conduct clinical studies in our practice, but for FDA trials requires a whole other level of scrutiny.
Right.
And that's what we're in the process of too. So it takes a long time for acceptance and for the academic world to allow these for them to support them openly. They will not hang their hat on something that doesn't have all the evidence in front of them.
And one of the problems that physicians run into is the conservative nature generally, and we usually go along the pattern of treating patients the way we were taught to. Now, if we have a career that's 30 or 40 years, and then on average, everybody's the average is somebody's out 15 or 20 years away from their residency program, that's the type of medicine they're practicing. And do patients really want that level of medicine that's 20 years old?
Right.
They want what's up in front of them now. They want what the science is showing. But one of the phrases that they use very frequently is everybody's doing evidence-based medicine. Right. Well, that's from exactly the way you've explained it. That's past. Okay, right. There's all this new data, new information, if they just listen. But now it seems to me a closed door, or a fairly closed door of the academic institutions that are very slow to adopt any new procedures. They're not open to it at all.
Sure. Yeah, it's interesting too, the way you phrased that. I do think, yes, we all practice evidence-based medicine. That's what we all practice. However, medicine and technology are moving far faster than we can conduct studies.
Yeah,
which is literally like looking at our evidence in the past, and it's no different than looking at the stars. It's light from the past. So we really need to be pushing limits in order to help our patients do better. And it does take a lack of complacency. Thing is, any job that you can imagine can have a complacency point where you just kind of accept it as that's the way it's going to be. But if you truly care about what you do, and you truly want to and are passionate about helping people get better, find solutions, just because you don't have it in your textbook doesn't mean it doesn't exist. I think that's what is going to drive, and that's what's always driven change and improvement for women.
Wait, I have a question. And maybe you guys don't know the answer to this, but how far behind are we, say, opposed to like Europe, what they're doing for sexual health? Are we way far behind? And I don't know.
It's all relative, right? So
yeah.
I think we're probably about 20 years behind in some areas. Mm-hmm. In some areas, we might be slightly above, but I think when it comes to more of the quality of life issues, they have a much different perspective on work-life balance and quality of life, and it's broad strokes in Europe, right? But I think there's a different perspective on quality of life there than there is here. Mm-hmm. So I think when it comes to these conditions, they're far ahead. We put other things in priority. But I think there's a lot to learn from them. That's why I enjoy being part of international societies as opposed to just the national societies, because you really get a perspective for the way people think outside of the U.S., where they may not have the luxuries that we have, or may not have the technologies, or they have a different perspective on what patients value and what their needs are.
Yeah, the other thing about the system of specialists in Europe and other parts of the world as opposed to the U.S. is that as they have more experience, and as they are older and further away from their residency, or at that time it's called being a registrar and surgical training, and they they actually have more physicians under them. It's like there's always a residency program for them that does the more routine work, and therefore they are really specialists then, because they're just seeing those that have been out longer are the consultants, and they're doing the specialized care, and they're seeing more a higher percentage of that than somebody doing just a general OBGYN who continues on for 40 years doing OB and a bit of GYN.
Yeah.
And never actually having enough surgery to be really particularly good at it.
Yeah, I think we were just talking about this recently, how our training here in the U.S. has changed dramatically because of work hour restrictions, which, yes, for safety reasons, I think it was important that we do that. However, nothing else changed. So, for example, when I trained and when you trained, our average work hour week was 100, 120 hours a week. That sounds insane for the average person. But for people who are always on the line, whether it's in, think of other fields that are not restricted to a 40-hour work week, where your job is always on, you become a different person. You think differently. You're capable of doing a lot more, and you're exposed to a lot more. So you become better at everything that you do. However, when you reduce the hours just to 80 hours a week, a huge chunk of your training is lost, and you may not realize it because you wouldn't know the difference. But when we went to an 80-hour work week, just as I was finishing residency, I felt like I was on break. I had time to go to the post office. I had to do things that normal people do. The banks are open when I get out, right? However, the process of training in the protection of the resident and for patient safety should have been balanced by a change in the structure of education. For example, as an OBGYN resident, you're trained to manage obstetrics, maternal fetal medicine, reproductive endocrinology. You kind of get little pieces of these other subspecialties, but for the most part, you're an obstetrician. And then you cover some basic emergency gynecology, but not routine day-to-day gynecology. So you really become very good at putting out fires, catching babies and putting out fires, but you never have a chance to talk to patients about their concerns, their needs, their wants. So when they reduce the work hours, they get even less of that. So the training in residencies for a menopausal medicine right now currently is pretty pathetic. It's less, over 60% feel that they got no training in residency for menopausal medicine. Forget sexual health. That's like a topic to study for your boards, and you just read through the chapter and then you go and do it. But there's so much more that's been missed. So,
I don't understand. Can't you cowboys do something about this?
No, we don't. What is the
Can't
expression?
You gather a group and
too many chiefs, not enough Indians, and I think that's there are too few of us.
Yeah.
I mean, we can spread the word, we can upset people, but I mean, this has been going on for a long time. It's very, very slow.
Yeah. So my concept is this, and this is, again, I'm always evolving in the way I think about how to best deliver this, because it's great that I'm able to offer services to my patients, whether it's difficulties with intercourse to difficulty in performance at work because of perimenopausal changes and the mental fog. I love that I can help people live their best, but at the moment, I still feel like I'm helping just one person at a time. And if I really feel that passionate about this, why aren't I doing more? So what we're doing is, we get involved in societies, we get involved in a variety of different platforms to speak and educate. We conduct research in our office, but I think we need to go beyond. And in the upcoming year, as I mentioned, I feel that there's going to be a need for further training in menopausal management and sexual health. That is something that is not touched on, and there's no time for it in residency. So that means you're not going to be practicing it in future unless you seek this education later. So we're starting what I call a functional urogynecology and intimate wellness fellowship in the upcoming year to start propagating this information. The knowledge and the research that needs to be done for data collection and for supporting our recommendations and therapies needs to be done if we really want it to grow.
Just go back to you're starting a fellowship. What does that mean exactly?
So fellowship is another term for advanced training, whether it's in a form of a preceptorship, which is what used to be done here for urogynecology, before it became a boarded specialty. So specialists like OBGYNs would then go and spend a year-long preceptorship with Dr. Ostergaard in Southern California, for example, and then that person then goes back to their facility and becomes that expert in urogynecology. However, that's evolved. It takes 40 years for a subspecialty to develop. So starting with preceptorships for a year, then you go do, then it goes to 2 years because they add on a research aspect to it. Then eventually, once there's enough, I think it was a minimum of 20 accredited programs before they can form a board. So that goes on for a long time before you can actually form a board. So in the meantime, what we're doing is it's an unaccredited 1-year preceptorship or fellowship.
So you're bringing someone into your practice.
That's right.
And they're learning from you.
They're going to be shadowing me, learning from me, and applying their knowledge, as well as conducting clinical research in the office that it needs to just keep going. We currently are bringing on a already fellowship trained urogynecologist to do an extra year of training. So I guess a PGY 8 year, an 8th year of training, just in intimate wellness and functional urogynecology. What I mean by functional urogynecology is taking all the conditions that we treat as a urogynecologist, but looking at the root cause elements that contributed to it or will continue at making it worse, which is why all urogynecologic conditions worsen over time.
Right.
Incontinence starts early and it gets worse. Prolapse starts early, from the results of childbirth and time, but then time and aging make it worse. So why aren't we addressing the root cause issues? How about we continue or recommend physical therapy after every delivery like they do in Europe? Why don't we recognize incontinence early in the 30-year-old instead of the 60-year-old? Because of the lack of information and these concepts of, you're too young to have that done yet. A 30-year-old that's leaking is just as bothered, if not more, than the 60-year-old that's leaking, right? And their quality of life suffers early.
Yeah.
So really treating patients, not just the end result in fixing a problem, but then educating them afterwards for behavioral changes, lifestyle changes, how to improve their pelvic floor behaviors, because a lot of the things that we do these days, particularly in the health field, in the fitness world, like CrossFit, they really miss the boat when it comes to women's pelvic health.
Right.
30% of CrossFitters, this is a recent study by a colleague from Brazil, 30% of CrossFitters have incontinence that are nulliparous, no children.
Yeah.
Right. And
Not surprised at all. I've seen, grade 3, stage 3 prolapse in a 20-year-old who's just an athlete and doing too much weight training, and it just destroys the pelvic floor.
Yeah.
And particularly if they have children on top of that, they're more likely to get it than not.
Sure, absolutely.
So the goal with the fellowship program would be to start creating this awareness and this training about something that isn't happening right now in med school, right? So you're creating a program, and that person would be with you for a year, and then you'd pull somebody else in.
That's right.
So then you're just kind of spreading this.
Yeah, I think that's the best way that I can further this along. Because I had a talk with on a panel recently about the deficiencies in residency for menopausal training, just speaking about menopause only, and how the dearth of information that residents are coming out with. And I ventured to suggest that it's not just improving residency training exposure, because there's still a time limit, and most of them aren't going to practice it. I think those that are interested are going to need to move on to a subspecialty training in sexual health and menopausal management, menopausal medicine, to really master and identify patients' needs. There's so many misconceptions about menopause that people don't even know what that is. They don't know when it happens. They have this misconception that it's a transition point, that they bounce back, that this phase will pass and you'll be back to normal in about a year. That is so not true.
Yeah.
They're,
Do you see that people are going through menopause earlier now than before?
I don't think they're going through earlier. I think through social media and through the technologies that we have now, people are becoming more aware that that these are not normal. And
Right,
they may
the
not know it's
perimenopause. Yeah.
That's right. They may not even associate with menopause, but the mental fog, the weight gain, the loss of libido, all exist without hot flashes, which is why it's also very confusing. Patients think that, well, we chalk it up to life. Well, I'm working hard. I've got a lot of stress, my family, my finances. So of course you're wiped out. So they kind of chalk it up to the wrong thing, but realize they may not have realized that beginning at 30, they started losing half of their testosterone production. Women produce as much testosterone, far more testosterone than you think naturally, which is reduced by 50% by the time they're 40. And then their estrogen symptoms don't come on until their 50s when they finally stop ovulating. So with that transition point, the late 30s to 40s, a lot of women experience this decline in performance, whether it's at home or at work, and they just chalk it up to life. But it's really the moment when really we should be capturing these patients, identifying their needs, and helping them perform better, because we're not retiring at 30 or 40 or 50.
Yeah, and actually, because you brought up testosterone, that's a huge part of your practice. I want to talk about that, because a lot of women, their physicians don't even check their testosterone.
That's right.
Yeah. So I want to hear about that part of your practice.
Yeah.
And I also want to know how much of your practice is surgical now, or
Sure.
how many things have been solved by the other things you're doing. Those two things.
I think there's still going to always be a need for the corrective nature of surgery, because we're still having children, we're still having babies, and gravity always exists, right? Even if we improve our health as a society, and we're all we're not overweight, and we don't have any smoking issues or any of those other habits that contribute to these things, gravity and pregnancies and life still exist. And then, of course, genetic predispositions. So I think the surgical aspect is still there. It is still a third of my practice. It always, but it now involves more than just correcting the past. It's also addressing the concerns that women have as they age, right? We all change as we age. We all have appearance changes that we might like or might not like, right? We go from being pudgy as babies, and then we grow into adults, and then where does that fat go? If fat goes somewhere else or transitions somewhere else. So things change, and that's a natural process of life. But sometimes confidence impacts performance as well. Confidence, both in the real world with what people can see, which is why makeup and clothing matter, and aesthetics and cosmetic surgery happens, because patients want to feel better about themselves. Sometimes it's because of deficiencies or injuries or traumas, but most times it's just because of life. Same thing happens with urogenital function and vulvar appearance and labia, as well as sexual performance. So when patients have these concerns that they don't know who to talk to about, they go to the internet and look and search and try to find solutions in people that can help. So there's still the surgical aspect that we offer, that is not the urogynecologic approach just to fix bladders and prolapse, but also to enhance sexual function, sensitivity, restore support, and then of course appearance and confidence. So what falls under the cosmetic gynecology isn't necessarily just cosmetic; it's also functional.
Yeah.
The other thing that
and then testosterone.
Yeah.
Okay. Let's not forget testosterone.
Let's not, because I think it's huge.
Yeah.
And, I'm always referring to women but I know it's for men, being used for men, but I think it's sort of, women don't understand the importance of testosterone. So,
well, we use a lot in our practice, certainly.
Both men and women need estrogen and testosterone. It is not testosterone for men, estrogens for women. Both need both. In fact, a male with no estrogen is a huge cardiovascular risk and is not a healthy male.
Yeah.
A female with no testosterone has performance issues that impact everything, from muscle mass and weight gain to increasing cardiovascular risk, because part of their estrogen also comes from their testosterone. So both are necessary. So testosterone, women are born with the capacity to make both testosterone and estrogen. And over time, as their testosterone levels decrease, they do experience symptoms of performance that impact performance, whether it be from memory and to libido, drive, motivation, sleep. So the testosterone effect on the women's brains is extremely important for their day-to-day functionality. Estrogen has an important role on connective tissue support, cardiovascular support, what keeps the blood vessels flexible and stretchy as opposed to rigid and hard, urogenital tissues, and bone strength. So women's dependency on estrogen, which is greater than men's, but they still have just as much of a dependency on testosterone as men do for our day-to-day performance. So testosterone is a big part of our practice, particularly in the perimenopausal patient. Because if you think about what is it nowadays, when is it that women peak in their careers? It's not 30s. It's not 40s. It's in their 50s. They're at the top of the food chain in their world, in their business. And it's at a point where they're also transitioning hormonally, which can impact their ability to perform their job.
Yeah. I mean, our patients have been calling in sick. They're like, I've had to call in sick. And I mean, it's horrible.
Right. I'm sorry, go ahead.
No, it's just, it's like you said, it's the busiest time. And that's what they say. This is the busiest time of my life.
Yeah.
When it hits.
49% of the workforce are women. I believe it was about 16% of them are in upper management positions. And the vast majority of them are in their 50s. Right. So the work hour loss, there's studies out there that predict the work hour loss and financial loss to performance, not only from calling out sick and ability to present themselves, but their inability or their desire to leave the workforce early. So the most valued employee that you have is leaving at a time at their peak of their career because there's not enough accommodations for their symptoms. Or they don't have solutions to address it, and the fear of not persecution, but the fear of not being taken seriously if they're complaining of these symptoms.
Yeah.
So it's a very difficult time for women. So that is a big area that we focus on, is helping women in the perimenopausal transition, meaning they're not menopausal yet, they're still having periods, but they're experiencing all of the symptoms and impact on their day-to-day life. So that is the patient that I feel that we're helping in tremendously, because it's impacting everything from work and home and their health.
Yeah, and you're doing, well, last time we chatted and visited you, you were doing a lot of pellets. Is that still the case?
I think that is probably still the large proponent. There's lots of ways of delivering hormones, and I look at it in like a lot of things, good, better, best kind of range. So good is, you can handle symptoms with doesn't take much. Any kind of even a phytoestrogen can help with symptom relief, but is it helping you with your health needs? It may not be. Better would be a myriad of administrations for estrogen, testosterone, like topical creams, injectables, and orals. Each of those come with pros and cons, and they're better than nothing. But they're also, the predictability is variable. The response is quite variable, and most of those preparations are one size fits most, unless you go into the compounded world. So, like a lot of medications that are available commercially through insurance models and pharmacies are one size fits most. So if that's, you get small, medium, or large, and if it doesn't fit, then I guess it's not for you, which is unfortunate. When we can create the same medication from the same base through a compounding process that is more specific to the patient. And you can do that with topicals, and you can do that with pellets. The reason why a lot of our patients prefer pellets is compliance and predictability. So for those I think you're familiar with pellets, but pellets are, you do a lot of pellets in your practice too.
Yeah.
They're highly compressed bioidentical hormones that are compressed into tic-tac size pellets. These pellets are then released over time. They're placed under the skin, and they're released by cardiac output, by the blood flow around them. So as blood goes past them, it dissolves like a tic-tac in your mouth, or like a pebble in a stream, slowly gets worn away. And because of the pharmacokinetics and the mechanics of the pellet and the size and the dose, we can predict how long they last. So generally for women, will last about 3 to 4 months. For men, 5 to 6 months, depending on the protocol that you use, which gives you a very predictable peak and a very predictable decline. And the decline is gradual, as opposed to the daily administrations that have a rapid drop-off.
Mm-hmm.
So for that reason, a lot of our patients, for compliance issues, they don't want to have to take everything every day. They want to know what they're getting every day.
Yeah.
I think pellets help them in that sense.
The transdermal approach is also much safer in terms of blood clots.
Absolutely.
And complications.
Absolutely. And that's, and I'm glad you brought that up. Here's another little pet peeve of mine that exists, is how, the way we're trained is hormonal issues when it comes to whether it's ovarian production or uterine issues, is give them birth control, right? Mm-hmm. So what did we do with birth controls? We give women birth controls that are a concentration in the past, concentration that increases their platelet function from their liver, not their platelet, their coagulation profile from their liver, because the birth control pills get absorbed through their liver. So when these coagulation factors increase, they increase their risk for blood clots, which is why on birth control pills, a little black box warning says, if you smoke, or if you're pregnant, or if you have any blood clotting history, do not take these, because it's going to increase that risk. So as a result of that, what have we done in the birth control world is we've driven down the concentration of estrogen in birth control pills to a low levels. Those lower levels minimize the risk for blood clots and blood pressure issues, all because of this artificial passage of hormones through your liver that we're not used to doing. So here's the problem. Birth control pills essentially will hijack your ovarian production.
Yeah.
Right. So it stops the natural cycle, and it's only getting what you're getting. So you're giving young women menopausal level estrogen.
Yeah.
This is a big pet peeve of mine, because I'll see patients that are on birth control for the last 20 years. They behave and feel and react just like they're in menopause. Vaginal dryness, painful intercourse, increasing UTIs, loss of libido. It's unfortunate, but because we're trying to avoid the complication from an artificially induced process by giving them oral birth control, we've just created a different problem. Whereas transdermals avoid the whole problem. Transdermal creams, patches, even subcutaneous injections or pellets avoid that process in the liver. They don't increase the blood clots. They don't increase blood pressure issues.
Yeah.
No, because I've never thought about this, but quite a few people that are kind of in that perimenopause, they think everything is being taken care of because they're on a low dose birth control pill. So what you're saying is that that's not true, that it's not taking care of things, that they should go on to a hormone replacement therapy treatment?
It's addressing one problem only. It's only addressing that low level estrogen in a birth control pill for the perimenopausal patient, is only addressing the symptoms. They can stop complaining.
Okay.
That's how I think it underserves them. It doesn't address their testosterone deficiency, that if you, according to what I said earlier, that their 50% reduction in testosterone happens between 30 and 40. Now this patient's in their late 40s. They're already testosterone deficient and they're not being replaced.
Okay. Yeah.
So there's only addressing the symptoms, and then the goal for those patients that were put on birth control oftentimes is, we'll take it away in 5 years, because they keep repeating the same mantra.
Yeah.
Yeah, we've got a lot of patients that are in their 40s, particularly, that come in thinking in terms of perimenopause, but that actually their estrogen levels are fine, and they're still ovulating.
Right.
But what they need is a testosterone.
That's exactly right.
And so it works really well for that, and pellets are great for that. I have a greater percentage of patients using creams than pellets, and I started doing pellets really only because patients wanted it. Mm-hmm. I had patients come from out of town. They were already on pellets. And so, why couldn't I do that? which I did, and now we do pellet insertions every day. It's really a good, convenient way for doing it.
Yeah.
So one thing about menopause, just going back a little bit, is that it's a hugely destructive time for women if they don't do anything about it.
Right.
The hot flashes, night sweats may only last for a short period of time, but the risk of cardiovascular disease goes up, osteoporosis, et cetera, and I mean, even when they're going through the hot flashes and night sweats, this is a huge reaction of the catecholamines with those hot flashes, the blood pressure changes, and so on. They're just really unhealthy things to happen that they may be putting up with that and thinking they're doing very well, but it's just not good for them.
Right.
So,
yeah.
And we've been struggling with this whole hormone replacement issue because of mistakes of academia.
Mm-hmm.
It's just the false interpretation, or let's say incomplete evaluation of the Women's Health Initiative study, which Karen, you were talking about Europe before. That's where we're behind by 20 or 30 years.
Yeah, absolutely.
From just not thinking wisely about estrogen, particularly.
Right. No, it's true. It's unfortunate that millions of women suffered for the last 22 years since the WHA study. It's not until recently that through reevaluation of the studies, though they've been ongoing, now that there's enough voices out there that have completely now disregard most of the recommendations or the fears that came out of the WHI study.
Yeah.
But that's going to take a long time to undo. It's very similar to the anti-vaccine campaigns because of autism and vaccines, right? Through an adulterated study that has now been pulled and redacted.
Yes, right.
But to undo this concept that autism came from vaccines is causing diseases to come back.
Yeah,
that we've eradicated nearly.
Yeah.
Right. So it's going to be the same way. It's going to take us a long time, but it takes a lot of voices. And the reason why I like engaging with people like you and others that are very passionate about this is that patients need to hear that they have options, they have choices.
Right. Absolutely.
Okay. I have a one more question. Did you see Barbie?
I did.
Yay!
I did. I loved it. I thought it was great.
Wasn't it great? Like the last line.
It was very great. It was very empowering.
Yeah, it was.
Yeah,
I don't know why men have such a problem with seeing Barbie.
So
didn't. Many men. Okay, Nick, I'm putting you on the spot here. Okay, good. It's so good.
Yeah, I thought it was
such
very
a great
well made.
movie.
Yeah, absolutely.
And that last line, my daughter saw it way before Duncan and I saw it. And she said, "Oh, Mom, you have to go." And you have to go just for the last line. She wouldn't tell me what it was. So of course I'm watching the whole movie thinking, gosh, what is it going to be? And then it was, I'm here to see my gynecologist.
I love it.
I know. It's so good.
I forget what year was it, maybe 2019, maybe it was earlier. I can't remember. When gaslighting was I think it was Webster's word of the year, the new most commonly used word, right? It was not that long ago. And I truly feel that medical gaslighting has been prevalent in women's health for way too long. The increasing reach that we and others have in the community that are very outspoken about helping women achieve their health needs is allowing them, empowering them, and giving them a voice, which now their voice is driving care. I really do feel that the reason why there's improvement in an increase services for a lot of the conditions that we treat is because patient demand and their voice is getting louder. So I think that's very common in Europe, whereas here I think women have been somewhat stifled through stigmas and taboo and cultural beliefs. I'm very confident and very happy to see that there's ever increasing interest in this area. In these areas that we're talking about?
I didn't know. I was looking through your website last night, actually, and I noticed something that I didn't know you were doing. And I thought I was brilliant because I thought of it as well. I didn't know separately you were doing this. So you're brilliant as well. It was doing complimentary brief phone calls with new patients.
Yeah.
And we offer a 10-minute free consultation in most circumstances, male and female. So I can talk to the patient. It's very unusual for a patient to be able to do that in a normal practice. They can't, they're lucky if they see the doctor when they go in for their visit. But to talk to them about, see what the problem is and be able to direct them it saves so much time. I mean, if the patient is going to be a patient, that's time well spent anyway. And because I would be doing that if I hadn't talked to them before.
Right.
And the time that I would waste if I really had nothing to help them, which would be unusual,
right.
Or I'd need to send them somewhere else. So I didn't know you were doing that. Congratulations.
Yeah,
it's been really helpful.
I feel that like again, to save them time and to save us time, to allow have time for the patients that we have. We screen our patients ahead of time, particularly if they have concerns. So what I mean is patients screen us, really.
Oh,
so for those that have conditions that are definitely unique, or they haven't been able to find a solution or anybody near them, or conditions that are rare, like for example, for FGM, female genital mutilation. Right. We have patients that will reach out to us from other countries and say, I'd really like to understand a little bit more about what your process is and what can be done. And we talk to them. So that gives them an opportunity to speak to me and understand what my knowledge is. And also if there's a possibility, and then we move forward or don't. Same thing with lichen sclerosis patients. I have patients come from all over the country to treat their lichen sclerosis that they've been told different things for years. And so as a way of screening us in essence, but also us educating them on what their options are, if there's somebody that I know that's near them, I'd say, you know what, there's a great person that's next door to you or in a state over. So you don't have to fly all the way out to California. But in other cases, there aren't too many locations, or they'd rather come out to us because they feel comfortable. So I feel it valuable for the patient, even if I don't see them. I think it's important for me to do my part to help them, educate them, so they can find some help.
Yeah, it's really been a good move for us. We ask when we send the questionnaire out to you when we invited you to come on the program, a fun fact about you. You didn't actually fill out the form completely.
Oh, yeah.
But what I saw on it, or actually what we talked about the other day.
No, he filled it out. He did his homework.
All right, sorry.
Sorry, I have to argue here. You did it very well, by the way.
Okay, all right. Somehow I didn't see it.
Yeah.
Anyway, you're a bartender.
Yes, that's right.
He was a bar manager of a jazz club in New Jersey before starting med school.
That's right. Yeah, I took a slightly different path. College was an afterthought for me. I didn't think of going to college, and then I was going to be an electrician. But somehow, I guess through my friends and my circles, that I realized, maybe I'll give this a try. And I went to college. And then I discovered, how am I going to afford college? So I was always in the service industry as either a waiter or then I got into bartending. So that paid for college. Thank God. But then even then, I didn't go straight into med school. After I finished college, I was offered a position to open a new jazz club. And I hem and hawed over it. I was spending a month up at Yale doing some postgraduate work, and I thought about it for the month. I said, you know what, give me some time to think about this. And I thought, when am I going to have an opportunity to start a jazz club?
Yeah.
Ever. So I accepted the position. I went down there, had an in-person interview, and they said, well, you've got the job. And we opened a new jazz club. And I was there, next thing you know, I thought I would just do it for a year or so. I was there for almost 5 years.
Wow.
5 years. It was the most amazing experience that I ever had. And it's funny because, so I still consider myself a bartender because when I was on break, I'd go home, they'd give me shifts. when I was in med school, there was a women's club that heard that I was a bartender, and they wanted to learn how to make cocktails and how to present. And sure, I'll teach you how to do that. So it was really fun. And then to this day, when we have gatherings, I don't cook, I mix. So that's my job.
You guys have this in common.
Oh yeah?
Yeah.
All right, great.
Yeah,
So how'd you work today?
Peter Castillo, great to have you on. Thank you very much. Honestly, there's so much more that we can talk about, so we want you to come back.
I'd love that.
And
Thank
so
you.
we'll arrange that in the near future. But thanks very much for making the effort coming down here. And as I say, it's always a pleasure to spend some time with you.
The pleasure's
Thanks.
all mine. Thank you so much for having me.
Well, thanks for listening. We're getting really good feedback. We'd really appreciate a review on Apple Podcast, Spotify, or wherever you're listening. Thank you. You can always DM the Vagina Doctor Instagram with any questions or topics you'd like to learn more about, or email us. The Vagina Doctor Podcast. It all starts here.